Level up your skills with the RSNA Imaging AI Certificate Program, where on demand case based courses equip you to tackle today's challenges. Master the fundamentals, dive deeper with advanced topics, or obtain a diagnostic edge to meet those high demand moments. Designed with your busy life in mind, our foundational, advanced, emergency, and new CHESS certificates help you gain confidence, efficiency, and career advancement through a series of on-demand, easily digestible modules. rsna.org/AI-certificate.
Hello, and welcome to the RSNA Radiographics podcast. I am Marcela Lauar, a breast radiologist at Hospital Israelita Albert Einstein in São Paulo, Brazil, and one of the authors of the recently published radiographics article titled Breast Ultrasound, a Guide for Beginners. I'm here today with my co-author and colleague, Gabriela Merigue, who is also a radiologist at our institution.
Hi everyone, I'm Gabriela. So glad to be here. We are really excited to share some key insights from our article and walk you through the essentials of performing and interpreting breast ultrasound. Let's get started, Marcela. Could you start by explaining the role of ultrasound in breast cancer screening?
Absolutely. First, it is important to remember that breast cancer is the most commonly diagnosed cancer in women and the leading cause of cancer-related death after skin cancer. Screening typically begins at age 40, primarily with mammography. However, mammography can be less sensitive in women with dense breast tissue. In these cases, ultrasound can serve as a complement screening tool, especially for women at higher risk who can't undergo MRI. While MRI is the preferred method in these patients, it is not always available. Ultrasound, on the other hand, is widely accessible, doesn't involve ionizing radiation, and doesn't require contrast injection, making it a valuable alternative.
Besides its role in screening, what other indications are there for breast ultrasound?
There are quite a few. Breast ultrasound is commonly used to evaluate breast pain, palpable lumps, nipple discharge, and suspicious findings from mammography or MRI. It is also very helpful for assessing palpable abnormalities that are not clearly seen on other modalities. Additionally, ultrasound plays a key role in guiding interventional procedures like biopsies, cyst aspirations, marker placements, preoperative location, and abscess drainage.
Let's talk technique. What would you say are the most important factors in performing a high-quality ultrasound?
Great question. Because ultrasound is a highly operator-dependent modality, technique is critical to achieving diagnostic accuracy. It starts with the right transducer, usually a high-frequency linear probe between 12 and 18 MHz. Axioms should include at least two orthogonal planes, typically longitudinal, transverse, radial, and anti-radial, and the entire breast should be scanned. All quadrants, peripheral regions, and the lymphatic pathways. Most exams are performed with the patient in the supine position and the arms raised overhead. For patients with large breasts, a lateral decubitus position can help. Supine positioning combined with gentle compression reduces breast thickness, improves beam penetration, and aligns Cooper ligaments to minimize artifacts.
That's very helpful. Now, technical parameters are just as important in ensuring high-quality imaging. Could you walk us through the key settings?
Definitely. Adjusting technical parameters properly makes a big difference. For starters, gain should be set so that subcutaneous fats appears mid-grade, as other structures are compared to that baseline. If gain is too high or too low, it can lead to misinterpretation, like mistaking a cyst for a solid mass. While high-frequency transducers are ideal for breast imaging, in very dense tissue they may mimic non-mass-like lesions. In those cases, lowering the frequency and increasing compression can reduce artifacts. The field of view should include everything from the skin down to the pectoral muscle to avoid missing deep lesions. Panoramic or trapezoidal imaging can help capture larger findings, but including structures like the lungs may actually shrink the area of interest, so they are usually unnecessary. Lastly, the focal zone should be placed in the anterior third of the breast, between the skin and the pectoral muscle. When evaluating a lesion, these focal zones should be centered directly on the lesion.
Great tips. I'd also like to point out that in women with breast implants, the exam should be done in 2 steps. First, assess the breast parenchyma using the parameters you just described. Then, evaluate the implant itself. This often requires changes like increasing depth, lowering frequency, using trapezoidal imaging, and adjusting the focal zone to the implant level.
Absolutely, and I add that certain patient populations require special consideration. For instance, in male patients, we don't typically expect to find fibroglandular tissue or benign masses like fibroadenomas. In pregnant patients, breast tissue often appears more hyperechoic and may show ductal dilatation due to hormonal changes. And in infants, both male and female, breast buds can be present up to 12 months of age, usually from maternal hormonal stimulation. Finally, in adolescents, we begin to see fibroglandular tissue development in females.
That's a great overview. Now, let's talk about Doppler. How does it fit into breast ultrasound?
Well, Doppler is a useful tool for assessing vascular flow since neoplastic cells promote angiogenesis. Therefore, increased vascularity on Doppler can raise suspicion for malignancy. That said, the absence of vascularity doesn't rule out a mass. Doppler findings should be interpreted as part of a broader assessment, consistent with BI-RADS guidelines from the American College of Radiology.
Speaking of BI-RADS, it's worth emphasizing that it provides standardized terminology for breast imaging and reporting. We should always refer to the 5th edition, which is the most current. Now, let's shift to the axilla, which is a critical area in breast imaging. Marcela, could you explain how axillary scanning should be performed?
Of course, axillary evaluation is essential because ultrasound is very accurate in assessing lymph node morphology. The patient should be positioned supine with the arm abducted and externally rotated to fully expose the axilla. The scan should cover the area from the posterior border of the latissimus dorsi to the anterior border of the pectoralis major. Lymph nodes are categorized by levels according to the pectoralis minor. Level 1 is lateral to the pectoralis minor, level 2 is deep to the pectoralis minor, and level 3 is medial to the pectoralis minor.
Lymph nodes are especially important when it comes to cancer staging and treatment decisions. How should they be assessed?
Normal lymph nodes have a thin cortex, a fatty hilum, and a central hilar vascularity. In breast cancer, metastatic cells often enter through afferent vessels and accumulate in the cortex, leading to focal or diffuse thickening. They may also promote new angiogenesis, resulting in peripheral vascularization, which is a red flag.
Before we wrap up, let's talk briefly about MRI target ultrasound. This type of exam is often used to evaluate MRI-detected lesion ahead of biopsy planning. Marcela, could you walk us through what makes this kind of ultrasound different?
Sure. When performing MRI target ultrasound, it is important to correlate findings by considering the lesion's characteristics, depth, location, and surrounding tissue. Lesions may appear different due to compression, as round shapes may look oval and they often appear smaller. Correlation is usually best when the lesion is in areas with more breast tissue. For peripheral or superficial lesions, compression may distort the anatomy. Besides, lesion location can be predicted using MRI axial plane and the nipple as a reference point. Finally, it's key to analyze the lesion's position relative to the parenchymal zones and the anterior and posterior fascial layers.
Thank you, Marcela, for those great insights. We also want to thank RSNA, the radiographics team, and all of our co-authors Lavínia Dias, Erika Federici, Aline Costa, Ivni Yonekura, Michelle Lee, and Anna Resi for their significant contribution to this work.
We hope today's episode helps healthcare professionals better understand and apply breast ultrasound in clinical practice. Be sure to subscribe and rate this podcast as your engagement helps us reach even more listeners. And don't forget to read our full article available now on the Radiographics website, along with many other outstanding publications. Thanks again for joining us.